Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Our lecture today about the hypertensive disorder of pregnancy. Hypertensive disorder in pregnancy are a major cause of maternal and fetal mortality. Hypertensive disease complicated about 5 to 7% of all pregnancy. About the definition of the hypertension, blood pressure should be measured in a sitting position, the sphygmomanometer at the level of the heart, using a cuff wide enough to cover about 80% of arm. Systolic blood pressure should be 140 over the diastolic, about 90 mm mercury or more, measured in 2 consecutive occasions, 4 hours or more apart. An increase of 30 mm mercury systolic or 15 mm mercury diastolic blood pressure from the pre-pregnancy blood pressure, that means a case of hypertensive. About the type of the hypertensive, number 1, gestational hypertension, preeclampsia, eclampsia, chronic hypertension, preeclampsia superimposed on chronic hypertension. Gestational hypertension criteria with the patient of gestational hypertension, blood pressure should be more than or equal 140 over 90 mm mercury for the first time during pregnancy. No proteinuria. Blood pressure return to normal less than 12 weeks postpartum in perperium period, فترة النفاس. Final diagnosis made only postpartum. May have other sign of PE, preeclampsia, that means headache, epigastric discomfort, or thrombocytopenia. Another criteria of PE, preeclampsia minimum criteria blood pressure also should be 140 over 90 mm mercury after 20 week gestation, and in this case proteinuria should be present more than or equal 300 milligram per 24 hours or more than or equal 1 plus dipstick. The general urine when we done for her album. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Our lecture today about the hypertensive disorder of pregnancy. Hypertensive disorder in pregnancy are a major cause of maternal and fetal mortality. Hypertensive disease complicated about 5 to 7% of all pregnancy. About the definition of the hypertension, blood pressure should be measured in a sitting position, the sphygmomanometer at the level of the heart, using a cuff wide enough to cover about 80% of arm. Systolic blood pressure should be 140 over the diastolic, about 90 mm mercury or more, measured in 2 consecutive occasions, 4 hours or more apart. An increase of 30 mm mercury systolic or 15 mm mercury diastolic blood pressure from the pre-pregnancy blood pressure, that means a case of hypertensive. About the type of the hypertensive, number 1, gestational hypertension, preeclampsia, eclampsia, chronic hypertension, preeclampsia superimposed on chronic hypertension. Gestational hypertension criteria with the patient of gestational hypertension, blood pressure should be more than or equal 140 over 90 mm mercury for the first time during pregnancy. No proteinuria. Blood pressure return to normal less than 12 weeks postpartum in perperium period, فترة النفاس. Final diagnosis made only postpartum. May have other sign of PE, preeclampsia, that means headache, epigastric discomfort, or thrombocytopenia. Another criteria of PE, preeclampsia minimum criteria blood pressure also should be 140 over 90 mm mercury after 20 week gestation, and in this case proteinuria should be present more than or equal 300 milligram per 24 hours or more than or and equal 1 plus dipstick. The general urine, when we done for her albumin in urine, that means 1 plus or 2 plus with blood pressure present 140/90 and after gestational week 20 week of gestation, that means preeclampsia. Okay, this is the criteria of diagnosis of preeclampsia. Increased certainty of preeclampsia, blood pressure 1 more than or equal 160/110 millimeter mercury, proteinuria more than or equal 2 gram per 24 hours or more than 2 plus dipstick. Also in general urine exam. Serum creatinine more than 1.2 milligram per deciliter unless not to be previously elevated. Platelet less than 100 millimeter cubic. بالنسبة للوايت platelet بالcomplete blood picture, send the patient if she had above criteria of diagnosis of preeclampsia to exclude HELP syndrome, which mentioned in advanced slide. Another criteria, increased certainty of PE, microangiopathic hemolysis, increased lactic dehydrogenase enzyme, elevated alanine aminotransferase, ALT, and AST. Persist headache or other cerebral and visual disturbance. يعني ممكن المريضة تجي with blurred vision, gastric pain, and headache, sometimes temporarily blindness. This is increased certainty of preeclampsia. Eclampsia, by definition, is a seizure that cannot be attributed to other causes in a woman with preeclampsia. 1% of patients with preeclampsia develop eclampsia. يعني مو كل البيشنت اللي هم عندهم criteria of preeclampsia ممكن يصيرون eclampsia. هو only 1% of all patients develop preeclampsia. Chronic hypertension, criteria of chronic hypertension, blood pressure 140/90 before pregnancy or diagnosed before 20 weeks of gestation. يعني if patient coming to check up her blood pressure at 12 weeks, 3 months or 4 months of pregnancy and we find blood pressure 140/90, this diagnosis as chronic hypertension may be patient misdiagnosis. Chronic hypertension first diagnosed after 20 weeks and persists after 12 weeks of postpartum. Preeclampsia superimposed on chronic hypertension. The new onset proteinuria more than 300 milligram per 24 hours in hypertensive woman, but no proteinuria before 20-week gestation. A sudden increase in proteinuria or blood pressure and low platelet count in women with chronic hypertension and before 20 weeks of gestation, that termed as preeclampsia superimposed on chronic hypertension patient. Incidence and risk factor for preeclampsia. Preeclampsia occur in 6 to 8% of all live birth. Risk factor extremely of reproductive age, both less than 15 years and more than 35 years. Nearly parity, increase in patient with prime gravida. Black race, history of PE in first pregnancy and first degree female relative, her sister, her mother. History of PE in prior pregnancy. إذا كانت multiparous ممكن بالfirst pregnancy she developed preeclampsia. DM, diabetes mellitus, chronic renal disease, chronic hypertension, multiple pregnancy, twin, triplet, quadruplet, hydatiformal, non-immune hydrops fetalis, RH negative, and obesity. This all risk factor for development preeclampsia. The pathogenesis is by definition is multi-organic system involvement. يعني all the system starting from the CNS till the renal and respiratory and another system, also immune system and all system in the body. So the PE is by definition is multi-organic failure as a complication of PE. Summary of current hypothesis: immunological disturbance, abnormal placental implantation, and this leads to decreased placental perfusion and the production of the substance that activate or injure the endothelial cell of the blood vessels and lead to multi-organic system involvement. Another pathogenesis, CNS, similar to hypertensive encephalopathy, petechial hemorrhage, cross hemorrhage due to rupture, arteries, thrombosis of the arterioles, microinfarction, fibroid, cerebral edema, brainstem herniation, and maybe lead to the cerebral edema and death. The mechanism: cerebral hyperperfusion, vasospasm, and forced dilatation of the ventricle. Patient should be sent for CT scan. Half of the patient focal hypodensity in the white matter, post half of the cerebral hemisphere, and occasionally in the gray matter, and may represent petechial hemorrhage. Severe cases: IV intraventricular hemorrhage or subarachnoid hemorrhage, MRI abnormality in the cortical and subcortical white matter of the occipital and parietal area. EEG, non-specific changes. Pulmonary system. This may occur with severe preeclampsia or eclampsia, usually postpartum, may be due to excessive fluid administration with crystalloid and decreased plasma colloid pressure due to proteinuria, increase in patients with chronic hypertension and hypertensive cardiac disease, aspiration of gastric content with eclampsia due to repeated fit may lead to aspiration pneumonia. The cardiovascular system, plasma volume is reduced, the cause is unknown. Theories: generalized vasoconstriction with vascular permeability and lead to advocate the use of vasodilator, primary hypovolemia, hypoperfusion of the uterus, and the release of pressure substance and lead to hypertensive. Hypotension. Advocate the use of volume expanded and avoidance of diuretic. So, in emergency department should we avoid diuretic because of this causes which lead to decreased volume, plasma volume, and lead to CVA in some patients and maybe lead to oliguria for the amniotic fluid of the fetus. Another complication or complication that occur in CVS, cardiovascular system, high systematic vascular resistance, hyperdynamic ventricular function, and avoid aggressive fluid administration. Loss of the normal, refraction, and angiotensin II. The blood system, hemoconcentration, thrombocytopenia, fibrinogen increase, thrombin time increase, fibrin degradation product increase in 20% of patients, DIC, disseminated intracoagulopathy, microangiopathic hemolytic anemia, HELP syndrome, that's mean مختصر of hemolytic H والE elevated liver enzyme and والLP هو low platelet count, and this may be as mentioned in the diagnostic criteria of P should be done, and if elevated that goes with diagnosis of preeclampsia. Found in 10% of patients with severe PE. Kidney characteristic lesion, glomerular nephrosis, and the swelling of the glomerular capillary endothelium, and decreased GFR, glomerular filtration rate. decrease creatinine clearance, increase plasma creatinine, increase uric acid, proteinuria, renal tubular necrosis and renal failure. Eyes, visual disturbance due to retinal artery vasospasm, retinal detachment, cortical blindness, occipital lobe ischemia and function edema, and may lead to temporally for 8 days postpartum or prepartum. Liver minimal involvement with fibrin deposition, periorbital hemorrhage, bleeding from this lesion, leading to hepatic rupture, hepatic infarction, HELP syndrome, as mentioned previously in previous slide, hemolysis, elevated liver function test, and low platelet. Uteroplacental perfusion, vasospasm lead to compromised placental perfusion and increased perinatal morbidity and mortality. Doppler velocimetry, systolic to diastolic velocimetry ratio of umbilical and uterine artery lead to 20% normal and 15% of umbilical ممكن normal and ممكن abnormal uterine blood vessels. 40% both abnormal. Histological changes in placental bed, defective trophoblastic invasion of the spiral arterioles, residual vessels but not myometrium vessels are invaded by trophoblastic, and this lead to diagnosis of H-mole hydatidiform, which form from only trophoblastic tissue and lead to severe PE. Characteristic lipid-rich lesion in the uteroplacental arteries. Prevention of preeclampsia, calcium supplement, purely question mark till now, but maybe decrease the risk of preeclampsia or develop eclampsia. Fish oil and low dose aspirin, selective suppression of thromboxane synthesized by the platelet, and sparing endothelial prostacyclin production. Not effective in preventing PE, but maybe prevent prevent clotting of blood vessels when the vasoconstriction was occurred. Antioxidant, vitamin C, vitamin E supplement, significant reduction in PE. And this all supplement till now no proof from FDA. Symptom and sign of patients with preeclampsia: increased blood pressure, proteinuria, edema of the face and hand, and headache, visual disturbance, gastric, and exaggerated reflex. Maybe 1 or 2 or 3 or all of these criteria present with the patient and reach the diagnosis. Fetal and maternal risk factor: fetal IUGR, intrauterine growth restriction, oligohydramnia, placental infarction, placental abruption, prematurity, uteroplacental insufficiency, perinatal death. Maternal CNS, seizure, stroke, DIC, disseminated intracoagulopathy, increased cesarean section, renal failure, hepatic failure, and maybe complicated and multi-organ failure lead to death. Classification of PE according to the severity of the patient presentation. Systolic blood pressure 160 over 110 in 2 occasions at least 6 hours apart. Proteinuria more than or equal 5 grams per 24 hours. Oliguria less than 500 cc per 24 hours. Cerebral or visual symptom: gastric and right upper quadrant pain due to liver involvement, pulmonary edema or cyanosis, low platelets, increased liver enzyme, intrauterine growth restriction by ultrasound. Mild PE, any PE that is not considerable severe. يعني ممكن الكرايتيريا اللي 1 أو 2 منها ممكن just the patient present with albumin in urine, but blood pressure 130 over 90 or 130 over 80. This mean on borderline, maybe mild, should be need good observation and follow up by her senior or antenatal care. Our management, first of all, we have objective. First of all, termination of pregnancy with the least possible trauma to the mother and fetus. Birth of an infant who subsequently thrive, complete restoration of the health to the mother, seizure prophylaxis, blood pressure control, and delivery, according to the severity presentation of the patient. First of all, hospitalization. Women with a new onset of blood pressure more than 140/90 should be administered and 4 hours apart, as mentioned in the first slide. Then we decide and set for investigation and ultrasound finding. Then we decide if the patient needs admission or discharge the patient. Worsening blood pressure, that means should be hospitalization to monitoring blood pressure, or maybe need delivery of the patient. Development of proteinuria in addition to existing blood pressure. Maybe in the future we develop proteinuria or elevated liver enzyme, and patients should complain of normal or hypertension due to any cause. Maybe patient develop antepartum hemorrhage, نزف قبل الولادة, or any complication lead to hypertension. So the blood pressure alone, not a criteria of PE, should be sent for another investigation. Initial hospital management. Observe for headache, visual distress, gastric pain, and rapid weight gain. Weight daily, analysis for proteinuria every 2 days, and then daily blood pressure in sitting position every 4 hours, except during sleep. Blood investigation, complete blood picture, white PC, HB, platelets, serum creatinine, liver and renal function test, frequent evaluation of fetal size and amniotic fluid, reduce physical activity but not absolute bed rest, and normal diet and fluid intake. Should be decrease physical activity because may aggravate hair sign and symptom of preeclampsia. Further management depends on severity of the PE, duration of gestation, condition of the cervix, complete resolution of the sign and symptom does not occur till after delivery, lines of management, termination of pregnancy, antihypertensive drug, anticonvulsant therapy, home health care. If blood pressure improves within a few days, patient can be managed as outpatient and home blood pressure, and during protein monitoring, instruction to come to hospital if she has wearing symptom or rest at home. And rest at home as complication may develop, or she complains another sign if she had severe headache, elevated blood pressure, oliguria, decreased fetal movement, should be administered to the hospital. Termination of pregnancy, depending on we have indication and the method of termination. Indication: term pregnancy with mild or severe PE. If the patient present 37 weeks till 40 weeks, why we delay the patient? Why maybe develop severe complication, and then she developed eclampsia? Maybe we lost the baby. Should be termination of pregnancy. Severe PE regardless of the gestational age. Some patients come at 24 weeks or 28 weeks. So if the patient is preterm, should be terminate the pregnancy because severe PE, and this preeclampsia had a multi-organic failure and lead to complication to the patient. May lose the patient if leave it without termination of pregnancy. Eclampsia, patient must be stabilized and delivery immediately. Preterm with mild PE, assess fetal well-being by non-stress test and biophysical profile and Doppler study. Method of termination: induction of labor with prostaglandin to ripening the cervix followed by IV oxytocin. Elective cesarean section in case of severe PE with unfavorable cervix may be develop eclampsia, so the patient should be delivered as early as possible to avoid another complication. In cases of mild PE, Antihypertensive therapy. The aim of antihypertensive therapy is to lower the blood pressure and reduce the risk of maternal CVA without reducing uterine blood flow and compromising the fetus. There are a variety of antihypertensive used in management of preeclampsia. Methyl-dopa is a centrally acting antihypertensive agent اللي هو متوفر والكل يعني إن شاء الله تعرفوه. هو الدوميت الاسم التجاري مالته. الدوز مالته 250 ملغ. We starting according to case presentation. It has a long established safety record in pregnancy. However, it can only be given orally. It takes upward of 24 hours to take effective and range of unpleasant side effects, including sedation and depression. These properties limit its usefulness and starting dose from 25 mg up to 2 gram. يعني ممكن المريضة نبدي وياها 1 tablet per day till 8 tablets per day according to the severity of elevated blood pressure. Another type هو اللابيتالول. Is an alpha blocking and beta blocking agent. It too has a good safety record in pregnancy and can be given orally and intravenously. Nifedipine, another type, is a calcium channel blocker with a rapid onset of action. It can, however, cause severe headache that may mimic worsening disease. There is no benefit of antihypertensive therapy. Reduction in the maternal blood pressure with labetalol or nifedipine may lead to intrauterine growth restriction. So we use in limited cases and if elevated moderate to severe cases. The angiotensin converting enzyme contraindicated because lead to intrauterine growth restriction, bony malformation of the fetal limb contracture, and another congenital abnormality اللي هو الكابوتين. For example, severe PE antihypertensive therapy is used to control blood pressure until the patient delivers or in preterm for 48 hours to allow time for glucocorticoid administration for fetal lung maturity then delivery. يعني البيشنت تحتاج ستيرويد فممكن إذا كنترول البلد بريشر ممكن نعطيها لحد ما يصير إذا كانت بريتير طبعا لحد ما يصير كنترول. If not control blood pressure, termination in spite of يعني decadron or dexamethasone given. Another antihypertensive therapy which given for severe PE or eclampsia. If the patient present with high blood pressure 160 over 110 and according to her gestational age should be administration maybe unconscious, maybe visual disturbance, maybe irritable, maybe loss of consciousness. So we start with her cannot be swallowing the tablet or a capsule. So this patient starting with her by intravenous infusion of antihypertensive. First of all, in emergency cases, hydralazine اللي هو apresolene. An arterial vasodilator is a commonly used drug and is a first-line agent for hypertensive emergency. Intravenous infusion or IV 5 to 10 mg per loss at 15 to 20 minutes interval when the diastolic blood pressure more than or equal 100 to 110 millimeter mercury or systolic blood pressure 160 millimeter mercury and above. Nifedipine 10 mg per oral repeated in 30 minutes and labetalol 10 mg IV. This nifedipine may be as a capsule and gel material should be administration as squeezing in the mouth under tongue and swallowing may be occur. And another drug is rarely used but the most common use هو الهيدرالازين and النيفيديبين. labetalol less common available. So الفيرست لاين هو الهيدرولازين اللي هو أبريسولين. الكالسيوم channel blocker are being used with increased frequency. However, they are generally limited to severe hypertension that is a response to another medication. Calcium channel blocker may be cause tocolysis in the third trimester, and congenital abnormality are not associated with their use. Also, الكالسيوم channel blocker يستعمل ك tocolytic بالنسبة للمرضى اللي يعانون من premature uterine contraction, so it is safe for patient in the third trimester. And another treatment here, fluid therapy, hyperosmotic agent not recommended because intravascular influx of fluid and subsequent escape of the fluid to vital organ and lead to pulmonary edema and cerebral edema. 60 to 120 ml per hour excessive fluid administration lead to complication, pulmonary or cerebral edema. A treatment for patient with eclampsia. Patient come to the labor room as a fit and loss of consciousness, irritable. First of all, protect airway, ABC. Position in the left lateral side, prevent aspiration and aid uterine perfusion. This lead to good oxygenation for baby. Prevent injury from height. Oxygenation, magnesium sulfate after seizure has terminated. Prevent and control of convulsion by magnesium sulfate, IV infusion, 4 gram, loading dose in ml of intravenous fluid over 20 minutes and 2 gram per hours maintenance dose. And measuring how to assess or control or avoid side effect of magnesium sulfate by measuring serum magnesium level at 4 to 6 hours and 24 hours after delivery. 25% of seizure may occur postpartum, so avoid eclampsia after delivery and avoid toxicity by monitoring patellar reflex, respiratory rate and during output. If develop toxicity of the magnesium sulfate, give patient antidote calcium gluconate 1 gram IV. Magnesium sulfate decrease myometrial contractility, and this as also used as a tocolytic may lead to postpartum hemorrhage. And another drugs use, if not available, magnesium sulfate, phenytoin or diazepam, and this decrease 50% in maternal mortality and 67% in convulsion. Infant should be observed and sent for premature unit to assess oxygenation of the fetus. Prognosis: maternal death rare due to cerebral hemorrhage, aspiration pneumonia, hypoxic encephalopathy, thromboembolic and hepatic fracture, renal failure and anesthesia. ممكن complication as was mentioned firstly with pathogenesis is multi-organic failure, but it is very common complication and may lead to maternal death. Recurrence of preeclampsia 25 إلى 33% بالprimary and 70% بالmultiparas. Primary gravida PE and preeclampsia before 30 weeks 40% may occur. Preeclampsia HELP syndrome develop 5%. About chronic hypertension, incidence of chronic hypertension 0.5 to 4% of all patients, 80% essential hypertension, 20 due to renal disease. Signs symptom increase in age, more than 30, obese, multiparas women, diabetes, renal disease, black race, family history, and difficulty to differentiate hypertension with superimposed PE from chronic hypertension with renal disease, and both have proteinuria. Maybe misdiagnosis. Investigation: chest X-ray, ECG, increased serum creatinine, and renal and liver function test. Maternal complications: superimposed PE In 1/3 of patients, increased risk of placenta, antepartum hemorrhage, and acute tubular and cortical necrosis of the renal system. Increased renal function is if renal function is creatinine less than 1.5 milligram per deciliter in pregnancy does not change the course of renal disease. If renal function is affected prior to pregnancy, the deterioration of the renal function occurs more rapid in pregnancy because the pregnancy may affect normal physiological changes occur in respiratory and renal system during physiological changes of pregnancy. Fetal complication, prematurity, preterm labor, intrauterine growth restriction, stillbirth, intrauterine death ممكن occur, fetal distress due to abruptio placenta or hypoxia or chronic intrauterine hypoasphyxia. Treatment: no benefit of treating mild chronic hypertension unless she develop high blood pressure 170 or 180 over 110. In pregnancy, should be monitored for worsening chronic hypertension or superimposed if develop proteinuria or not. Patients with severe chronic hypertension should have their blood pressure controlled